Dr. Marsh, what's the aim of these new guidelines? Well, the aim is really to provide a resource and not for the top-level, professional sports people, but for parents, teachers and coaches of young people playing sport. The guidelines basically offer some expert information from a GP and emergency physician, and myself as a neurosurgeon about what the condition is, also how to identify the symptoms, and how to manage it. If any of your listeners have ever had a concussion doing sports, you'll know how frightening it can be. It's confusing and painful and difficult sometimes for teachers, parents or whoever to work out if someone with concussion is okay. I mean, we hope to remedy that. And how do we know when someone is suffering from concussion? Well, obviously the person's actually knocked out. It's clear, but not all patients actually lose consciousness, often following a hard knock to the head. They become disorientated or experience headaches, nausea or vomiting, and these are signs of concussion, and they may clear initially, but then return when the individual actually undertakes further physical activity, where they start to train, say. So it can actually take quite a while for things to really clear up. The essence of it is that people shouldn't start playing again until those warning signs have completely subsided. Yes. And you say that waiting anything less than 14 days after all the symptoms have cleared will be too early to return. That's right. If they go back too early, they risk a second concussion. And as we know from professional athletes, they may have to give up their sport if they have too many concussions. So it's better, particularly in a young person with a developing brain, to allow all of the symptoms to settle and only then return to play well. Usually return to train first, then return to play after that. It used to be thought that receiving another concussion could lead to severe brain swelling, and that could be fatal or at least involve a visit to the emergency room. I think the evidence is fairly slim for that. What we do know, though, is that the compounding effect of having one concussion followed by another seems to be more severe just the one. So it's always better to let the brain recover fully before playing again. Right? So who's at the highest risk of sports concussion? Well, actually, a concussion can happen whenever anyone receives a blow to the head. Usually it's a sort of twisting blow, not a straight-on blow. But obviously people playing sports like rugby with his bodily contact stand more chance of being at the receiving end of such a blow. But having said that it's just as likely to affect kids kicking a ball around the park. It is to affect top professional players in big matches. Do you think that youth sports need specialist concussion doctors on hand, like the professionals do? There's always a risk, and we know that it happens from time to time. But, I mean, most games, even the most dangerous ones, are without incident at all. I think people are involved in running youth sports, whether they be referees, coaches, or parents, can be made aware of how to manage concussion, the signs that they need to look out for, and maybe the warnings of something more serious, so that they can take the appropriate actions. But I think always having a doctor on the sidelines, where young people are playing, is just an overreaction, right? In the USA, college football is big business. They're trialing helmet sensors and impact sensors. Do you think that's something we need everywhere? Well, I don't think it'll come to that. I think there are two scenarios here. The first is a concussions, a one-off event following a significant blow to the head, right? The second is quite different and involves chronic traumatic encephalopathy. This comes about particularly in American football, where players use their helmets and heads almost like weapons. That type of repeated impact seems to add up over the player's career. That's something we've heard being discussed mostly in the USA. Naturally, there's interest generally in protecting players, particularly at the professional levels of sport, but I see that is a different matter to the management of concussion itself. Dr. Pamela Skeleton, consultant cardiologist at this hospital, and I'm talking about the recent SPRINT study into the effects of setting lower blood pressure targets, which in turn affects the advice and medication which patients are given. Going to describe the patients who were selected, how the trial was conducted, and the implications of its results for us all as health professionals. First, the trial itself. It involved over 9,000 hypertensive participants aged 50 plus, most of whom were on blood pressure medication. They were randomly assigned to one of two groups. One with a goal of less than 120 mm systolic BP. The other with a goal of less than 140 mm, the traditional standard. The intention was to follow these patients for 5 years, factoring in the usual dropout rate, and it turned out. However, the trial was stopped after just 3 years, thanks to an all-cause mortality reduction of nearly 30% for the 120 group, which was definitive and shocking. But wonderful. As I mentioned, the participants were over 50s, and it goes without saying that people age, they develop more diseases and health problems as a matter of course, but there was a specific group of over 75s who did just as well as younger patients. Before the trial, some medics refer to the natural stiffening of the arteries with aging, suggesting that 120 was the lower target for the over 75, risking an increase of dizzy spells, which would affect general well-being. But this concern turned out to be unfounded. Others thought there would be a failure to take the number of tablets needed to reach a BP of 120, especially among older participants again. This wasn't an issue. The average needed was just 3 per day. The over 75s, already on various drugs, didn't object to extra medication. Participants from this age group, who didn't finish the trial, were taken out because some conditions, which were already present, worsened. For example, in some cases, obesity levels rose too high to manage their blood pressure. Participants were given standard drugs. Nothing experimental, just drugs that are readily available. And low cost. Another key factor was that blood pressure was measured in a very specific way rather than give patients an arm cuff or at home. 24-hour ambulatory monitoring, an automated machine, was used at the hospital. This took 3 separate readings and averaged them. Also, readings were taken while staff were out of the room to avoid what's called white coat syndrome in patients. Some of you may be familiar with the Accord study into blood pressure levels several years ago, which in some respects was similar to SPRINT. There are some differences though. So for example, Accord was about half the size of SPRINT, and unlike SPRINT, the Accord study allowed diabetic patients to take part. Despite this, in general, the Accord participants were rather lower risk than those in the SPRINT trial. Probably because of the slightly lower average age. The Accord trial didn't share a statistically significant benefit for overall cardiovascular outcomes, but there was a clear 40% reduction in strokes, even though that was a secondary outcome. So to summarize, the SPRINT trial seems to support 120 as a recommended blood pressure target. This is doubtless a landmark study, and importantly, one which was sponsored by government rather than by the interests of pharmaceutical corporations. I recommend a note, of course. SPRINT does contradict previous findings. The Cochrane review in 2011, for example, said that lowering to under 140 didn't produce a change in the risk of death overall. All, however, we must bear in mind. The Cochrane was looking retrospectively at trials, which weren't actually focused on the same particular issue. So, is worth doing a full and systematic evaluation to see whether SPRINT trial fits in with what we already know. It's interesting that a few GPS have already been working with older patients to hit lower blood pressure goals, and the new data will doubtless encourage greater take-up of this more. His line of attack? But the SPRINT results don't mean that everyone with hypertension should be dropping to under 120 glass to achieve those lower levels. It's unlikely that lifestyle changes alone would be enough. It could well require several antihypertensive drugs as well. There remain some unanswered questions, of course, for example, whether other groups like those with a lower heart attack risk need to keep their blood pressure that low. So while SPRINT can help guide doctors' decisions about some patients, it doesn't mean that a new universal standard for blood pressure is in order. Instead, it's a good reason for everyone to discuss with their doctor.